Hello, my name is Michelle Morand. I am a precision cancer medicine educator and advocate, and I am here today with Alexander Rolland, founder and chief scientist at Cancer Treatment Options and Management and Liquid Biopsy Labs, and the Cancer Guy YouTube channel. So Alex has prepared a presentation for you, specifically if you have ER-positive breast cancer, to talk about a type of drug, a class of drugs, CDK4/6 inhibitors. There's some very important information that if this is in any way relevant to you or someone you know about, you absolutely want to stay tuned for the next few minutes. Because what Alex is about to share about some of the treatment options for this particular predisposition will make a big difference to the outcome of your care. Alex, tell us all about this.
Yes, by all means. So the standard care for breast cancer has changed over the years. Definitely a class of drugs called CDK4/6 inhibitors have been a game changer for estrogen-positive breast cancers. I suspect they're going to be moving into other types of cancers too, but for now, they're a main part of the standard care in CDK4/6 inhibitors. They were first used in the metastatic setting. So when women become metastatic, previously it had been intravenous chemo, and now this offers another few years of targeted therapy options that can be a significant benefit before having to go into the heavy-duty chemo-based approaches. So while these drugs have been initially used in the metastatic setting, recent data from a trial a few years ago called the MONARCH trial really was a game changer. It looked at one of the CDK4/6 inhibitors and used it in an early setting. So in other words, prior to women getting metastasis.
Okay.
And the goal of that was to see if you took it in a high-risk situation, in other words, if these were cases that had high risk of early recurrence, would it actually extend their remission time? And sure enough, it did. It greatly reduced the incidence of recurrence in these patients. And so this really kind of set things up to show that, wow, giving these drugs prior to metastasis actually prevents metastasis, rather than just waiting until the disease is metastatic and then trying to treat it. So what are they? CDK stands for cell-dependent kinase. It is basically a checkpoint. So when cells go through their reproduction cycle, what they do is they have these various checkpoints to make sure all of the things are working and that it's not too many mutations or damaged genes. And once they pass these checkpoints, then they can go on to divide and create two new daughter cells. What can happen in cancer is these checkpoints that would normally inhibit a cancer from going past a certain point in the cell cycle, they're broken. And they're usually tumor suppressor genes that control that. So the two genes, CDK4 and CDK6, are often over-amplified or overexpressed in these cancers. And what they do is if you have high CDK4/6, it allows you to override that CDK4/6 checkpoint, which is typically regulated by a gene. I believe it's RB1 that regulates that particular one. There's a whole bunch of different genes involved, and so it's not really important right now. The point is that these drugs will inhibit CDK4/6, CDK4 and CDK6, and prevent that cell cycle checkpoint from going through and preventing the cell from reproducing. So one of the first ones was palbociclib, and it was a game changer. It came out in 2016, and it really made a difference in some women. It added years to their remission rates and cancer-free survival time. And then following this, another second-generation inhibitor, which is slightly better than palbociclib, called ribociclib, was approved in 2018. And then finally, in 2021, a third-generation drug called abemaciclib was FDA approved. Now, the important thing to understand is when you have a first-generation drug, the lessons learned from that drug are usually dealt with in the second-generation drug. And also, when you have a second-generation drug, then if there's problems with that, then those lessons are usually dealt with, and you get a third-generation drug. So the generation of the drug is an actual development of the drug, both in reduction of side effects and efficacy.
You can think of them as an evolution.
Evolution, yes, of CDK4/6 inhibitors.
Yeah.
So since palbociclib has been around the longest, most oncologists like to start with this drug. And I hear every day, oh, CDK4/6 inhibitors are all the same. Let's just go with the one that's easiest to access and that I have most experience with. However, they are not all the same. There is a radical difference between these drugs, and how you use these drugs really needs to be dependent on the patient. So let's just briefly talk about side effects, because that's one of the first things that comes up when you're doing an adjuvant therapy. One of the most common side effects, or what we refer to as adverse events, from palbociclib and ribociclib is what we call hematological AEs. And typically the most common one is severe neutropenia, which is very low white blood cell counts. This can be a fairly significant problem. In fact, I get at least 4 or 5 patients a month who actually tried palbociclib and only lasted on it for a month or two and then went off it because the neutropenia was so bad. And this can be a serious issue because these drugs can add years to people's lives. So not being able to take them is a problem.
Yeah.
And so often what doctors would do is they'll reduce the dosage. They can also put you on something that increases your white blood cell counts, but all in all, these two drugs do have higher rates of that, and they can result in this neutropenia. So out of all 3 of these drugs, as you might assume, the most superior drug is abemaciclib. Abemaciclib has greater affinity for CDK4 and other inhibitors and less affinity for CDK6. What's important about that is we learned from using these, from palbociclib and ribociclib, we learned that actually it's CDK4 that really needs to be inhibited. And CDK6 didn't really need to be inhibited as much. And in fact, when you inhibit CDK6, that is one of the main causes of the neutropenia. So when they created abemaciclib, they focused on repression of CDK4 at a higher rate because that actually stopped the cancer better. And then they stopped targeting CDK6, or much greater reduced targeting of CDK6. And the consequence of that was a drug that worked much better for reducing the cancer and did not have as many cases of neutropenia. So an evolution of the drug based on molecular analysis and patient stratification. So additionally, abemaciclib has what's called CNS activity, or it's got superior CNS activity. So palbociclib and ribociclib, they have a little bit of CNS activity. When I say CNS activity, what I mean is the central nervous system. So a drug is normally prevented from going into the brain and the spinal and that area, the CNS, by something called the blood-brain barrier. And some drugs can pass it, other drugs can't. This is important to have a drug that can pass the blood-brain barrier, because what it does is it reduces brain metastasis or prevents brain metastasis, but it also is important for treating brain metastasis. So if you have a drug that goes into the brain, then it's going to be able to target the tumor cells in the brain and work on them. This is a really important consideration because abemaciclib is able to prevent and treat CNS and brain metastasis. In fact, in a recent trial on heavily pretreated breast cancer patients with brain metastasis, significant increases significant pretreated. So they've had chemo, they've had all kinds of different things. There wasn't a lot of options for these women. And they found that when they got abemaciclib, they had up to a 38% reduction in the size of the brain tumor lesions they were looking at. And that was across all of the samples. And so I put the reference down below there. So fairly significant data there.
What I also really appreciate hearing about that is that it can help prevent any metastasis, because we know this type of cancer preferentially metastasizes to the brain, and is it bone as well?
No, this particular cancer preferentially targets the bone and then the liver and so on, and the lungs. Actually, it's HER2 positive breast cancer are specific for brain metastasis or early brain metastasis. However, we get many cases of ER positive breast cancers that have metastasized to the brain. So, I mean, if you have the disease long enough, there's a good chance it will eventually go to the brain.
So being on a drug that helps prevent brain metastasis is pretty precious. Yeah,
very much so. Also, abemaciclib has multiple targets. So unlike palbociclib and ribociclib, abemaciclib is a potent inhibitor of other kinases other than CDK4/6, including the CDK1, cyclin B, which appears to cause arrest in part of the cell cycle called G2 phase. And then also cyclin CDK2 and cyclin E and A, which are both implicated in resistance to palbociclib. So in other words, that was one of the mechanisms that created resistance to palbociclib was the CDK2 and cyclin E and A activity. And so I put the references there too. And then also importantly, I just touched on this a little bit. I didn't want to get into it because we could spend a lot of time on resistance mutations. Some of those resistance mutations are PIK3CA, HER2 mutations, estrogen receptor mutations. There's a lot of different potential mutations. And so when someone has these resistance mutations, then the standard treatments such as endocrine therapy or, targeting of the estrogen receptor with fulvestrant or tamoxifen, sometimes these things won't work as well as they should because of mutations in those genes. So importantly, abemaciclib can inhibit kinases that are not inhibited by palbociclib and ribociclib, such as CDK9, 7, 2, and 1, but also GSK3 alpha and beta, and CAMK2 gamma and delta. And as such, it is able to inhibit cell proliferation, which is growth, in RB deficient cells. Now, RB1 is a gene. It's a tumor suppressor gene. It's a very important gene, and it's often mutated or turned off in this type of cancer. So one of the most important things we do when we try to decide if a patient is going to be resistant to palbociclib or ribociclib is we look and see whether they have an intact RB1 gene or not. And, all in all, we do see it quite a bit. So if you have done DNA testing, you'll want to know if your RB1 is active or not, if it's not non-mutated. And if it's non-mutated, then potentially you could do palbociclib or ribociclib. But if it's mutated, you definitely won't get any benefit from palbociclib and ribociclib. Now, this is just one mutation I looked at. There's a whole bunch of different ones, as I mentioned, PIK3CA, HER2, and estrogen receptor mutations that could also result in resistance to palbociclib and ribociclib. So also, now I don't like to compare across trials, but this was a trial, or this is a variety of trials where they said, let's look at the efficacy of these different CDK4/6 inhibitors in general. And so this is a very rough analysis where they compared these, because you can't really compare trials between trials. You have to compare the data sets within a single trial. Because trials are done differently. They're done in different patient populations. It's a variety of reasons you shouldn't do that. But overall, abemaciclib in advanced breast cancer typically results in up to a 67-month overall survival. And that's a significant improvement when you think of that. So, prior to being on, if you weren't taking abemaciclib, here's an extra 67.1 months that you could add to your life versus 63.9 for ribociclib and 53.9 for palbociclib. Now, once again, these are averages. They're called medians. Overall survival refers to, and we did a video on statistics. So if you don't understand what overall survival is and progression-free survival, I suggest you look at that video on statistics. But overall survival basically is the period of time in a trial when 50% of the patients in the trial that are on the drug die from their cancer. So it's only 50%. The other 50% may live longer or may have a quicker occurrence, but it's a 50%, which is the average. Now we're getting to the point of this video. This all was a background on abemaciclib and CDK4/6 inhibitors. I really feel is so important for doctors to understand and patients to understand and educate their doctors on it. These drugs are not the same. And one of the biggest things that we have found is that when we get a patient who is on a palbociclib or ribociclib and they stop responding to it, we always want to try abemaciclib. We always push for that. And we have found that in many cases, even if a patient progresses on palbociclib or ribociclib, giving them abemaciclib extends their life. They get a bunch of time on that. We've had patients get up to 2-3 years on abemaciclib that had failed after a couple months on palbociclib. So it really is all about what genes are being mutated. And this also gets back to tumor DNA sequencing and how important it is in deciding what drugs to get on. But we even if you haven't had tumor DNA sequencing, if you haven't had tumor DNA sequencing, you don't know what your mutations are, you don't know what your resistance mutations are, then just go for abemaciclib, because it's going to be the one that has the highest chance of working with any potential mutations you may or may not have. We're talking about re-challenging now. So previous retrospective data showed, and this is the basis of what we started doing years ago, that abemaciclib treatment after disease progression or prior palbociclib resulted in significant benefits. In this study, the overall response rate, how many patients out of 100 responded, and clinical benefit rate were 16% and 44% respectively. The median progression-free survival was 5.3 months. But what is really important here, so even though the progression-free survival wasn't that long, remember that's 50% of the patients, not all of them. What is really important is the median time before these patients had to go to chemotherapy or the next line of treatment for these cases was 33.9 months. So, over 2 years, definitely. So this is a significant benefit here because it's putting off the chemo. And just by doing subsequent abemaciclib after progression on a previous CDK4/6 inhibitor. So that was previous data from 2022. But in a recent study that just came out, like literally a very short period of time ago, when they looked at a post-MONARCH trial analysis, what they did was they had this study where they had patients who had disease progression on a CDK4/6 inhibitor plus an AI, which stands for aromatase inhibitor. Aromatase inhibitor is standard treatment for ER-positive breast cancers. It inhibits the body's ability to create estrogen through the aromatase pathway, which basically turns steroids and testosterone into estrogen. I won't get into that. But anyways, when these patients have progressed on a CDK4/6 inhibitor for advanced breast cancer, ABC means advanced breast cancer, or who relapsed on or after CDK4/6 inhibitor plus an aromatase inhibitor as adjuvant therapy, benefited from abemaciclib plus fulvestrant versus only fulvestrant alone. Fulvestrant is an estrogen receptor inhibitor, is part of standard care. In this trial, the prior CDK4/6 inhibitors were mostly palbociclib, as you can see, 59% of the patients had progressed on palbociclib, 33% had progressed on ribociclib, and 8% had actually progressed on abemaciclib. So this is an interesting thing, as they found that even if they progressed on abemaciclib, after they stopped taking it, re-challenge was potentially beneficial. So in this study, the hazard ratio basically tells you whether something is going to be positive or negative value. So a hazard ratio of less than 1 means that there is a benefit from the drug. A hazard ratio above 1 means there's no benefit from the drug. In fact, it's worse. And so the lower you go below 1, the better the drug. So for this particular case, a hazard ratio of 0.73 actually is comparable to a 27% reduction in risk. So you take 1 minus the 0.73 and you get 27, or 0.27 times 100 is 27%. So that's how you use these hazard ratios. And so this hazard ratio was, 27% reduction with 6-month progression-free survival rates of 50% versus 37% for fulvestrant by itself, or standard care. So the overall response rate was improved with abemaciclib compared to placebo, 17 versus 7%. That's fairly significant. It's an extra 10 patients there that are responding. These are patients with measurable disease. And the progression-free survival was also improved by 45%, as you can see. So 1 minus 55 is 45%. And what's interesting in this study is that the overall survival, which is a median, and is when 50% of the patients in the trial die from their cancer, has not been reached yet. So that tells us more than 50% of the patients on this trial are still alive.
Yeah, had a good response. Wow.
Yeah. And so what is really important too is another new study by Kalinsky et al. And this one is very fascinating. So as I mentioned, resistance mutations for breast cancer include mutations in the ESR1, which is the estrogen receptor alpha gene, or the PIK3CA. We see a lot of PIK3CA mutations, and they really result in a resistance to treatment and a very fast and progressive disease, as do estrogen receptor 1 mutations. And so they found that when they looked at all the subgroups, they all got a great response, including patients that had these estrogen receptor and PIK3CA mutated variations that normally would have had a really bad prognosis. It leveled out the playing field for them. So this is a really fascinating finding. And it really does show us the importance of knowing which drug to go on. Precision oncology, the right drug at the right time for the right person. Well, what we know now is that abemaciclib is the right drug across different subtypes for most breast cancer patients, estrogen-positive breast cancer patients, and importantly, getting it earlier is better.
Yeah, before we have that metastasis.
Yeah.
Yeah, and
So,
yeah.
summary. I know which drug I would use. How
Yeah.
about you?
Yeah, no doubt. Let me summarize here. Let me make sure I understood all this for you folks watching at home. That was a lot to take in, and it's really important. Obviously, you can pause, rewind, and all the stuff. But if I heard you right, Alex, we have some significant benefits here. The first one being the abemaciclib targets the CDK4 more than the 6, and it seems like the 6 is the part that has the neutropenia side effect. So this particular drug, because of its priority to CDK4, has less of the neutropenia side effect. This I'm hyper focusing on because I can't tell you the number of times oncologists, when we've made this recommendation, the very first argument has been, oh, no, that has far more side effects than the ribociclib.
I know.
So I need you guys to be super keen, super aware. That is not true. And the studies that Alex included here will help you to back that up. Of course, we can as well. But point is, if you're going to go talk to your doctor about this, be prepared for them to say, oh, no, it's got more side effects. And then be able to say, no, actually, it doesn't. Studies show that this particular drug produces less neutropenia than the palbo or the ribo.
Yeah. So one of the biggest problems here, though, is that abemaciclib does cause diarrhea and it's particularly bad for the first 2-3 months. It tends to go away after a while, but it's easily treated with a anti-diarrhea medication. It's not a problem. But when doctors tell patients of the side effects, they say, you could have severe diarrhea or you could have neutropenia. Most patients don't even know what neutropenia is until they get it. And they're like, oh, I don't want the diarrhea. Thank you. That's a bad side effect. And so, they say, oh, I don't want to do it because of the side effects. Well, I think neutropenia is way worse than diarrhea. Sure, you have some very bad cases of diarrhea, but let's face it, neutropenia is the common one that prevents treatments, not necessarily diarrhea.
Right, is the neutropenia will get your doctor taking you off any therapy, whereas diarrhea you can take a pill for.
Yeah.
So just remember, fewer side effects on this. And again, Alex included some of the studies for you to maybe print off, take with you if you're going to speak to your doctor about this. Another key factor Alex just mentioned is this particular drug can cross the blood-brain barrier. So that means it can target existing brain tumors and it can help prevent metastasis to the brain. These other two drugs cannot do that. Okay. Also, abemaciclib has multiple targets, not just a couple or not just the one of the 4 and the 6. And so you're covering a wider swath of possible problems here. And second to that, Alex also mentioned this particular drug, abemaciclib, can address some of the most common resistance mutations like RB1 and PIK3CA, amongst others. This is really important because if you haven't had thorough tumor testing and you don't know if you have these mutations and you're on one of the other drugs and it stops working, your doctor won't know why. They won't know that there's another drug that could actually work for you. So ideally have your tumor tested and find out if you've got these mutations. But if that's not in the cards, you just got to get on something fast. Know that the abemaciclib can address these very common resistance mutations, and that'll make the drug work for you. And as you saw, the overall survival on the abemaciclib is higher than either of the other two drugs. And apparently, last but not least, if you're on this drug, and you take a break for whatever reason, you can re-challenge, I guess is the term, but the point is you can take it again and experience more benefit. It's not like you tap out on it and it's not going to benefit you anymore. And that's very important. And I'm reiterating these points for you, even though Alex covered them well, because these are the things you need to know and be solid on if you're going to go speak to your doctor about this and get a prescription. If you're going to ask your oncologist to change anything that they're doing for you, rightly or wrongly, you have to come with the evidence. You have to have a sound argument. You have to be asking for something that has proper approvals and efficacy. And you have to be able to know the objections that they're going to put up, like side effects. You're already on something that's just fine. It does the same, whatever it is. You've already been on it. Now you know that none of those objections actually carry any weight and that you can push through those and get the drug that you need.
Yeah, and preferably get your doctor to watch this video, because you know, the hope is here is that doctors will watch this video and it will help them understand better, you know, why it's really important to go with the abemaciclib rather than palbo and ribo, you know,
Yeah.
if
If you'd
possible.
like, we can send you a like a PDF of this PowerPoint.
Hmm.
You might have more luck slipping a PDF of the PowerPoint under your doctor's nose than getting them to watch a video. The
Yes.
effect will be the same in the sense that they will understand better the benefits of these particular
Hmm.
modifications or this most current evolution of this particular type of therapy. So all that is to say, folks, if you would like our help, that's what we're here for. Aside from these free videos that we make, do make sure you subscribe, please, to our YouTube channel. That's how we know that people are watching and that we're benefiting you. Feel free to put in the comments any other things you'd like us to talk about or make videos on. We're here for you. So just let us know how we can help you. You can book a one-on-one consultation with Alex and his team, a complete treatment options review. I highly recommend it, 100%. You can join my free advocacy program where I will help you figure out, how do I get my doctor on board? How do I even figure out what's right for me? That's what I'm here for. We have drop-in meetings a couple times a week. And again, the YouTube channel. Subscribe, stay informed. Knowledge is power. Thank you for joining us.
Yeah. Bye.